Hello, welcome to Sonography Radiology Training Channel. This series of videos is about postpartum ultrasound findings. This is the third video in this video series with title of Retained Products of Conception. The outline of this presentation includes introduction, clinical and pathologic findings, incidence, diagnosis, ultrasound diagnosis, grayscale ultrasound findings, color Doppler ultrasound findings, diagnosis pitfalls including arteriovenous malformation versus enhanced myometrial vascularity, underlying endometrial abnormality, subinvolution of the placental implantation site, and final teaching points. At first, introduction. Postpartum bleeding is a component of the normal physiologic process that occurs after delivery or miscarriage. You can find full explanation about postpartum hemorrhage in this video. Normally, bleeding decreases over the first postpartum week. When bleeding is excessive and uterine atony has been excluded as a cause, the next most common cause of postpartum bleeding is retained products of conception or RPOC. The placenta usually constitutes the majority of RPOC, and because of its highly vascular connection to the uterus, it provides a conduit for continued bleeding. Although accurate diagnosis of RPOC is a challenge both clinically and radiologically, it's important for guiding proper management. Clinical and pathologic findings. One of the most important clinical findings is postpartum hemorrhage. RPOC is one of the most common causes of both primary and secondary postpartum hemorrhage. Another clinical finding is pain or fever. The term retained products of conception refers to intrauterine tissue that develops after conception and persists after delivery or termination of pregnancy. The intrauterine tissue is often of placental trophoblastic origin since the placenta invades and attached to the uterine endometrium. The trophoblast forms numerous processes known as chorionic villi that invades the decidua basalis of the endometrium. The key to the microscopic diagnosis of RPOC is the presence of chorionic villi, which indicates the persistence of placental tissue. After delivery or termination of pregnancy, the remaining villi exhibit variable vascularity and increasing fibrosis, which may account for the observed variability in the vascularity of the retained placental tissue at Doppler ultrasound. Incidence. The reported incidence of RPOC seems to depend on the gestational age of the pregnancy, with RPOC occurring most frequently after second trimester of delivery or termination of pregnancy. Laboratory values such as white blood cell count and human chorionic gonadotropin level may not be helpful in the diagnosis of RPOC because they can be elevated in the normal postpartum setting. However, color Doppler ultrasound is an important tool in the accurate diagnosis of RPOC. Early diagnosis is critical for directing clinical management of bleeding and for preventing associated immediate complications such as perforation or infection, as well as future obstetric complications. Given the risk associated with surgical interventions, including perforation, infection, Asherman syndrome, and development of scar tissue, and as we know, any of which can have a long-term negative impact on future pregnancies, so accurate diagnosis is vital. Ultrasound diagnosis. Ultrasound is a useful diagnostic tool for triage of patients with postpartum hemorrhage and is more accurate than clinical presentation alone for the diagnosis of RPOC. Combined grayscale and color Doppler ultrasound is the first-line imaging modality for the diagnosis of suspected RPOC and allows real-time assessment of the uterine structures and blood flow, whereas MRI can be a useful adjunct imaging modality in complicated cases. The sensitivity and specificity of ultrasound for the diagnosis of RPOC varies widely based on the diagnostic criteria and the clinical setting. However, more recent studies have defined more robust grayscale and color Doppler ultrasound criteria with a high sensitivity and specificity for RPOC. Grayscale ultrasound finding. One of the findings is thickened endometrial echo complex. The most sensitive finding of RPOC at grayscale ultrasound is a thickened endometrial complex. This image is related to pathologically proved RPOC with a thickened EEC in a 29-year-old postpartum woman. This longitudinal transabdominal grayscale ultrasound image shows a markedly thickened EEC about 26 mm. According to some studies, the exact definition of thickened endometrium varies in the literature, ranging from 8 to 13 mm. But the EEC 10 mm as a cutoff value has a reported sensitivity of over than 80%. However, the specificity of this measurement is relatively low, about 20%, because a thickened EEC can be observed in postpartum patients with no RPOC. On the other hand, if the EEC is less than 10 mm in thickness, the negative predictive value for RPOC is about 63 to 80%. Thus, sonography appears to be more useful in excluding the diagnosis than in accurately making the diagnosis according to thickened endometrial echo complex. Another grayscale ultrasound finding is endometrial or intrauterine mass. An intrauterine mass is defined as a structure separate from the endometrium that is distinguishable in two orthogonal planes. This finding has a sensitivity of up to 29 to 79%, but a high positive predictive value of 80% for RPOC. This appearance, however, is not a specific or reliable sign, because hemorrhage or blood clot may also be echogenic. Color Doppler ultrasound findings. Color Doppler ultrasound further enhances diagnostic confidence in identifying RPOC. For example, blood clots will appear avascular at color Doppler ultrasound, whereas the detection of vascularity in a thickened endometrial echo complex or endometrial mass is likely to represent RPOC. The degree of vascularity in a thickened EEC or endometrial mass can help increase diagnostic confidence for the presence of RPOC. To better describe the typical color Doppler ultrasound findings of RPOC, the degree of vascularity of the endometrial component can be compared with the myometrial vascularity in the same image section and graded as type 0, 1, 2, or 3. But here is an important point. The vascularity should be bridging between the myometrium and endometrium. Type 0 vascularity, defined as no detectable vascularity in a thickened endometrial echocomplex or mass, may represent either a blood clot or avascular RPOC. This images is related to pathologically proved RPOC with type 0 vascularity in a 42-year-old woman with persistent bleeding 2 weeks after a miscarriage at 22 weeks gestation. This longitudinal endovaginal ultrasound image shows persistent thickening of the EEC about 28 mm and also distension of the endometrial canal by heterogeneous echogenic material. This longitudinal color Doppler ultrasound shows avascularity of the endometrium. Also, an avascular thickened endometrium could still represent RPOC. Avascular RPOC will probably pass spontaneously without intervention and is unlikely to cause severe bleeding. If any vascularity is detected in a thickened EEC or mass, the likelihood of RPOC increases substantially to a positive predictive value of 96%. Three vascularity patterns have been shown to increase diagnostic confidence and help direct clinical management of RPOC. Type 1 vascularity, defined as minimal vascularity less than that of the myometrium, which has a positive predictive value greater than 90%. These images show pathologically proved RPOC with type 1 vascularity in a 40-year-old woman with passing blood clots and open cervical os. This longitudinal transabdominal ultrasound image shows a thickened EEC about 39 mm. Longitudinal color Doppler ultrasound image shows a small focus of color follow within the EEC in comparison with myometrial vascularity. Type 2 vascularity, defined as moderate vascularity, nearly equal follow in the endometrium and myometrium, which has been shown to have a positive predictive value of 100%. Another one, these images, is related to pathologically proved RPOC with type 2 vascularity in a 29-year-old woman who had undergone a cesarean section 6 weeks earlier. This longitudinal endovaginal grayscale ultrasound image shows a large amount of echogenic material and a thickened EEC. Longitudinal color Doppler ultrasound image obtained in the same area shows endometrial material with moderate vascularity similar to that of the adjacent myometrium. Type 3 vascularity, defined as marked endometrial vascularity greater than of the normal myometrium in the same image section, which has also a positive predictive value of 100%. This image is related to RPOC with type 3 vascularity in a 22-year-old woman with a 1-week history of vaginal bleeding who had had a miscarriage 2 months earlier. This longitudinal endovaginal color Doppler ultrasound image shows a thickened EEC with marked vascularity involving both the endometrium and myometrium. Of note, type 3 vascularity can be so robust that it mimics an arteriovenous malformation at color Doppler ultrasound. The atrial follow velocity of type 3 RPOC can be 100 cm per second or higher, with a very low resistant spectral waveform and large vessels occasionally being evident. As I explained before, vascularity should always be seen extending from the myometrium into the endometrium. If vascularity is isolated to the myometrium, other diagnoses besides RPOC should be considered. Given the marked vascularity of type 3 RPOC, the obstetrician should be notified of this finding due to the theoretic risk of bleeding if a large vessel inadvertently becomes unroofed during DNC. Diagnosis pitfalls. Also, distinguishing RPOC from blood clots in the postpartum uterus is the most common challenge in this setting. The radiologist should be aware of several other rare but potential pitfalls that can mimic RPOC. AVM versus enhanced myometrial vascularity. The biggest pitfall in diagnosis is mistaking the marked vascularity of RPOC for an arteriovenous malformation. The true incidence of uterine AVM is not known, but this entity is rare and is likely overdiagnosed because the underlying disease is often either RPOC or related to subinvolution of the placental implantation site. Historically, the term AVM has been used to describe a striking myometrial vascularity identified on Doppler after a recent intrauterine pregnancy. This study at 2004 introduced the term Enhanced Myometrial vascularity to describe this sonographic finding when it is associated with retained pregnancy tissue. Unfortunately, the term AVM and EMV continue to be used interchangeably, leading to confusion as to the pathophysiology of these two different entities and, more importantly, their management. Congenital AVMs are rare lesions resulting from embryological maldevelopment and are not related to the placenta. These aberrant connections between arteries and veins may occur anywhere in the body, including the brain, and do not disappear spontaneously. On the other hand, enhanced myometrial vascularity represents a natural manifestation of the pathophysiology of retained pregnancy tissue. The term enhanced myometrial vascularity should only be used in the first weeks postnatally or following a non-viable, normally cited intrauterine pregnancy. Using AVM as a synonymous term for EMV should be avoided, as the former is a persistent congenital vascular malformation, whereas the latter is a pregnancy-related physiological condition. While selective embolization and/or vascular surgery are the key to management of the AVMs, embolization is rarely indicated in pregnancy-related EMV. Serious complications reported after selective uterine artery embolization include thromboembolic events, vesicovaginal and uteroenteric fistulae, buttock and labial necrosis, and septic shock. Also, there are obstetric and fertility-related consequences following embolization, include delayed subsequent pregnancy, abnormal placentation. You can find full explanation about placenta accreta spectrum in these videos, and subfertility due to intrauterine synechia or decreased ovarian reserve. Although these complications may be uncommon, embolization should only be considered in life-threatening indications. The reported prevalence of EMV ranges between 1.5 and 6.3%. In early pregnancy failure, an increased fallow in the intervillous space has been reported. This color Doppler imaging of miscarriage showing blood fallow in the presumed intervillous space. Towards the end of the pregnancy, about 700 milliliters of maternal blood follows the placenta each minute. Immediately after delivery of the placenta, myoepithelial and myometrial contractions constrict the myometrial vessels, preventing excessive maternal blood loss. These vessels are seen on grayscale ultrasonography as anechoic, irregular tubular structures in the myometrium. Doppler imaging may show unusually high fallow velocities, while the fallow in the radial and spiral vessels removed from the implantation site is not enhanced. These images show grayscale and power Doppler ultrasound images of RPOC after early miscarriage with underlying enhanced myometrial vascularity in two different patients. Please here note the tortuous dilated hypoechogenic vessels on grayscale ultrasound, which correspond to the dilated high-velocity myometrial vessels visible on power Doppler. This schematic diagram showing EMV underlying retained pregnancy tissue. According to the laws of hemodynamics, high-velocity circulation within the myometrium is possible only in the presence of a direct connection between the high-pressure arterial system and the low-pressure venous system, as seen in the placental bed. Once the retained pregnancy tissue is expelled completely, either spontaneously or by surgical intervention, the high-velocity vessels disappear, as in the normal third stage of labor. EMV beneath retained pregnancy tissue is therefore part of a normal physiological process, and so is its disappearance once the retained tissue has been removed or has passed. To better understanding this matter, it's better to review a teaching case together. This image is related to a 30-year-old female with lower abdominal pain after miscarriage 1 month ago, with no history of uterine instrumentation. This grayscale ultrasound image shows multiple serpiginous vascular channels at the uterine fundus and thickened endometrium also in transvaginal ultrasound. Color Doppler revealed turbulent follow with low resistance waveform. These appearances are consistent with enhanced myometrial vascularity, which is typically seen as a complication of pregnancy. But 7 weeks later, the EMV disappeared spontaneously, and as we know, a true AVM will not spontaneously regress. In cases of EMV, retained trophoblastic tissue is the most likely explanation of the high-velocity follow, but the amount of the residual tissue may sometimes be limited. This is the management algorithm of EMV. In the absence of heavy bleeding, EMV may be managed expectantly. The EMV should disappear as the retained pregnancy tissue is expelled or resorbed, as I explained in teaching case. In the case of extensive EMV, the patient should be informed that heavy bleeding may occur, necessitating emergency admission. Should this occur, surgical removal of the retained tissue is indicated. The earlier theory that high peak systolic follow correlates with the risk of heavy blood loss is not supported by the literature and should not be used to guide management. If life-threatening bleeding persists despite the above-mentioned management, selective embolization should be considered to avoid life-saving hysterectomy. But according to many experiences, this is a rare occurrence. Another pitfall is underlying endometrial abnormality. Another potential mimic of RPOC is an underlying endometrial abnormality such as endometrial polyp, submucosal fibroid, and invasive mole. Either of these entities may manifest as an endometrial mass with vascularity. These images are related to pathologically provascular endometrial polyp in a 23-year-old woman with vaginal bleeding who had undergone medical termination of pregnancy 2 months earlier. This longitudinal grayscale ultrasound image shows an echogenic mass with small cystic spaces within the endometrium. This longitudinal color Doppler ultrasound image shows marked vascularity within the mass, like RPOC, but pathologic analysis showed only fragments of weakly proliferative and decidualized endometrium with no evidence of RPOC. Usually, there is a single atrial vessel from the myometrium into the endometrium in endometrial polyp, and typical circumferential fallow in submucosal myoma. Invasive moles and RPOC may have some overlap of imaging findings, but the clinical picture usually allows differentiation. The presence of prior molar pregnancy with persistently elevated and increasing HCG levels is vital in making the diagnosis. The swallowing and relatively hypocellular villi correlate well with the imaging and gross appearances of molar tissue, namely multiple discrete fluid-filled sacs. At ultrasound, an invasive mole can appear as a poorly defined mass with anechoic areas that is located in the uterus. Color Doppler findings include increased vascularity predominantly in the myometrium, resulting from myometrial invasion. These images is related to invasive mole in a 40-year-old woman with an elevated HCG level. This longitudinal grayscale ultrasound image shows a heterogeneous and indistinct EEC. This longitudinal color Doppler ultrasound image shows areas of marked vascularity and invasion of the myometrium. Another pitfall is subinvolution of the placental implantation site. Subinvolution of the placental implantation site is an exceptionally rare postpartum condition in which the uterine vessels fail to involute following delivery. The postpartum uterus may appear unusually large with dilated myometrial vessels. These images is related to pathologically proved subinvolution of the placental implantation site in a 36-year-old woman who had undergone a cesarean section for twins 1.5 weeks earlier. This longitudinal transabdominal ultrasound image shows an enlarged uterus with large tubular hypoechoic areas in the myometrium. This longitudinal color Doppler ultrasound image demonstrates tubular hypoechoic areas representing large vessels within the myometrium, and pathologic analysis demonstrated ectasia of the uterine veins with subinvolution of the uteroplacental arteries and no evidence of RPOC. Although its exact cause is unknown, subinvolution of the placental implantation site is thought to be related to an abnormal immunologic recognition process similar to the preeclampsia. Risk factors for subinvolution include uterine atony, multiparity, cesarean section, uterine prolapse, and some other risk factors, and interestingly, RPOC. Now, please pay attention to these final teaching points. Sonography appears to be more useful in excluding the diagnosis RPOC according to thickened endometrial echo complex than in accurately making the diagnosis, because the EEC less than 10 mm in thickness has the negative predictive value for RPOC about 63 to 80%. Endometrial or intrauterine mass is not a specific or reliable sign for RPOC because hemorrhage or blood clot may also be echogenic. The degree of vascularity in a thickened EEC or endometrial mass can help increase diagnostic confidence for the presence of RPOC. Also, an avascular thickened endometrium could still represent RPOC. Avascular RPOC will probably pass spontaneously without intervention and is unlikely to cause severe bleeding. In color Doppler evaluation for RPOC, vascularity should always be seen extending from the myometrium into the endometrium. If vascularity is isolated to the myometrium, other diagnoses besides RPOC should be considered. The biggest pitfall in diagnosis is mistaking the marked vascularity of RPOC for an AVM. Using AVM as a synonymous term for EMV should be avoided, as the former is a persistent congenital vascular malformation, whereas the latter is a pregnancy-related physiological condition. EMV, venous retained pregnancy tissue, is therefore part of a normal physiological process, and so is its disappearance once the retained tissue has been removed or has passed. In the absence of heavy bleeding, EMV may be managed expectantly. The EMV should disappear as the retained pregnancy tissue is expelled or resorbed. In the case of extensive EMV, the patient should be informed that heavy bleeding may occur, necessitating emergency admission. The earlier theory that high peak systolic flow correlates with the risk of heavy blood loss is not supported by the literature and should not be used to guide management. Now, I suggest two others of my videos that are close to this video in terms of matter. And thank you for your attention.